Welcome to the second session in the webinar series, Applying Best Practices to Diverse Older Adults, sponsored by the Stanford Geriatric Education Center in collaboration with the California Area Health Education Centers, American Geriatric Society, and Natividad Medical Center. My name is Nate Gardner, and I will be your host for the session. We are very happy to have you join with us today as we present the program on Delirium Identification and Confusion Assessment Method, or CAM. If you need to communicate with the presenters after the session, you may do so by sending an email to stanfordgec@stanfordgec@stanford.edu. We need to let you know that the webinar is not supported by any commercial interest, and today's presenters have no financial relationships to disclose. Our first presenter today will be Dr. Yusra Hussain, followed by Ms. Kathleen Turner-Hubbard. Dr. Hussain is a clinical assistant professor at Stanford University. She is a board-certified internist and a geriatrician. She is currently the medical director of Aging Adult Services at Stanford, and she is also medical director of the CCRC and Manor Care Healthcare Center. Dr. Hussain is involved in the medical education at Stanford School of Medicine and the Fellowship Program for Geriatrics. Ms. Turner-Hubbard has been a geriatric nurse practitioner at Stanford Hospital and Clinic for the past 3 years, where she evaluates hospitalized geriatric patients with delirium. She's been a nurse practitioner for 30 years and has been working with older adults for more than 10 years.
Good afternoon, everyone. I would like to thank our sponsors for having us present this talk today. Our topic is Delirium Identification and Confusion Assessment Method. I would like to start off by 4 case vignettes that would hopefully illustrate delirium and the various presentations that it may show. So the first case is an 82-year-old female who was admitted for a total knee replacement. She has a past medical history significant for high blood pressure and lives independently. Was doing well until about her second night post-operatively when she presented with difficulty with sleeping. She was given 50 milligrams of diphenhydramine to allow her to sleep. Half an hour later, she fell, hit her head and had a laceration, and we were called on to evaluate her. The second case is of a Hispanic 85-year-old female with history with no significant past medical history who presented with urosepsis. She was put on IV antibiotics, and essentially whenever the staff came back to evaluate her, she responded with a smile and was not able to participate otherwise in with any conversations. Her primary language was Spanish, and there were no family members present at the bedside. The third case is of a 72-year-old male executive who was admitted for an abdominal hernia repair. He acutely became confused in the post-operative period, and again, we were called on to evaluate this patient. And the fourth case is of a 68-year-old Asian male with history of esophageal cancer. He was admitted to the hospital for surgical excision and reconstructive surgery. This poor man had poor pain control post-operatively and continued to decline despite medical care. So what's delirium? I'd like to start by defining the syndrome. It's a sudden change in mental status where the person may present with confusion, and that potentially develops over hours to days. The cardinal features of delirium are disorganized thinking. There is an altered sleep-wake cycle. So the person may have altered thought process. They may not know why they are there, and they have difficulty sleeping at nighttime. Most of the time, these patients can actually sleep most of the day, and then at nighttime, they stay awake for several hours, and then you get called on to assess this person with medical management. There is either increase or decrease in psychomotor activation. So this person can be either rather agitated, combative, restless, or they can be very sedated and also primarily not interested in any activities. And when the team comes around to get them out of bed, they are not interested in participation. There is also a perceptual, an altered perceptual disturbance. So this person, generally speaking, have altered sensations or sensory inputs. They may see things around. One of my patients presented with basically feeling that the room was flooding and was very scared to stay in her bed because she felt the water will come to her eventually. The other case I had is of a patient who jumped out of bed in the middle of the night thinking there was an earthquake, and he ended up falling and fracturing his hip. Some of you know these cases actually firsthand. So this is an altered perceptual disturbance in the sense that the patient is having altered input and sensory inputs into their system. And along with these signs, there is a reduced ability to maintain attention. So when you go and evaluate a patient with delirium, they generally have difficulty maintaining their concentration on you. So you ask them a question and they drift off either into a sleep, or they can be very fidgety. And these individuals, you ask them to answer certain questions, and they are looking at their certain papers in their hands or trying to look for things around, and they ask you, is this my phone? So they look at certain objects in the room that do not really necessarily mean anything to them, but they have an altered perceptual sensation of these particular objects. These clinical features do fluctuate. So at times you find these individuals very alert and oriented, and then an hour later or two you get called because this person is completely combative and pulling tubes and not willing to stay in the room. So these are essentially the cardinal features of delirium. Why is it important for us as healthcare providers to identify delirium? We see that there is a significant increase in morbidity and mortality associated with delirium. So the individuals who have delirium, generally speaking, have about 62% greater risk of mortality when compared to their counterparts. There is also a significant incidence of cognitive impairment associated with delirium. We used to think of delirium as being a disorder that primarily is of a temporary nature and resolved within days or weeks. However, we are finding with more studies and literature that it actually can remain, and about 40% of individuals who suffer from delirium may never return back to their baseline. With that, there is a significant increased cost to the healthcare system. The cost per individual varies anywhere from $16,000 to $64,000 per patient, and more than $143 billion per year, the cost of the healthcare system. This cost includes hospital costs and post-hospital costs, which includes institutionalization, rehabilitation costs, home care, and a caregiver burden as well. Because most of the time, a member of the family who would be in the position of a caregiver would have to take time off to be with the loved ones. This was a study that was published in the American Journal of Nursing in 2007. And it looked at the epidemiology of delirium in various units throughout the hospital. So you see on admission, it varies anywhere from 14 to 24%. The incident within the hospital, again, anywhere from 6 to 56%. The highest incident, however, we found is in the intensive care unit, and rightfully so, because those patients are the sickest of all. It is basically followed by a higher incidence in orthopedic surgery, followed by medical, cardiothoracic, medical, and surgical units. So I'd like to shift gears and talk about what are the risk factors. Can we identify patients with delirium? Because truthfully, preventing delirium is far more important than managing delirium when it happens. And so there are certain risk factors that patients bring in when they come into the hospital that put them at an increased risk for delirium. These risk factors are the age. So again, somebody who is 65 years is significantly at a higher risk than somebody who's 45 years when they come into the hospital. And by the same token, somebody who's 85 years, the risk of delirium just increases exponentially. The presence of a hearing or visual impairment also impacts delirium. So a person who has hearing impediment, they are again at increased risk for having delirium while they are in the hospital. Dehydration, malnutrition, again increases the risk for delirium, and pre-existing dementia increases the risk of delirium by about 2 to 3-fold. The presence of history of drug abuse or alcohol abuse again increases the risk of delirium, especially if it's not recognized, because these individuals will go into acute drug withdrawal and delirium secondary to that. And last but not least is the presence of a metabolic disorder, such as electrolyte abnormalities, infection, underlying process in the body that could also predispose them to delirium. So the second group of risk factors are precipitating risk factors. Some of these we do onto patients, unfortunately, when they come into the hospital, such as polycatheterization, such as IV hydration and all that, which restrict the movement of these individuals and again make them at a higher risk for having delirium or precipitate delirium. Acute hip fracture. So generally speaking, patients with hip fracture, they have a 30% chance of being delirious on admission. Cardiothoracic surgery again increases the risk of delirium significantly, and that may have to do with decreased blood supply or increase the use of anesthetic around the time of surgery. Acute blood loss again precipitate delirium. Pre-existing functional impairment. So a person who comes into the hospital with at least a history of one or two dependencies in their activities of daily living, by that virtue, they are at an increased risk of delirium. The higher the number of comorbidities, the more likely that they will have delirium. And then again, severe untreated pain. So a patient who lies in bed with significant pain, they can be subject to developing delirium. So not just pain medications that cause delirium, but also pain itself can cause delirium. Advanced cancer, and a lot of us who deal with cancer patients realize that, especially at end of life, there is a delirium associated with that state. And acute metabolic encephalopathy, again, can precipitate delirium. To continue with the precipitating factors, sleep disturbances. This is, again, something we do onto our patients, unfortunately. So a lot of patients who get admitted to the hospital, they are put on a routine schedule of vital sign checks every 4 hours, and their doctors order constant blood draws throughout the day, irrespective of the time of the day. And so they may be having a blood draw in the middle of the night or in the middle of their nap. That really significantly alters the sleep cycle of the individual. The presence of monitors in the unit, and especially if they are constantly beeping, that also of the person, of the individual. As I said, the use of restraints such as bladder, catheterization, IV, and other formal forms of restraint can also increase the risk of delirium. And medications, by far, has also shown to be the highest culprit for delirium. In one study we did here at Stanford, about 40% of our orthopedic patients actually had delirium secondary to medication use. And infections, again, increases the risk of delirium, especially in the elderly. And the last but not least, hypoxia, hypotension, and hyperperfusion all alter the level of oxygen to the brain and also expose the patient to delirium.
Hi, thank you so much for that introduction, Dr. Hussain. So we're going to go on now and talk a little bit further about delirium, and then we're going to talk about the how to assess for delirium. But I think the important thing is that within the hospital, it's really not uncommon for people to not recognize that the patient has delirium. Frequently, patients get misdiagnosed, and in fact, multiple studies have been done across the country looking at this issue, and physicians in general, about 2/3 of the physicians will actually fail to recognize their delirium in their patient. It's very possible that part of that failure is the fact that they really don't know the patient. These may be patients that have just come into the hospital setting. They've never met this physician before. It may be because of trauma. It may be because they were referred in. And The second thing is that nurses did a little bit better, so we as nurses can take pride in the fact that we did do a little bit better, but it's probably because nurses spend more time with the patients than the physicians do. They're at the bedside for longer periods of time and have an opportunity to view the patient's changes over the day. But the interesting thing that we found, and we even found this here at Stanford, was the fact that psychiatric referrals frequently for depression are actually because the patient actually has delirium. And so when the psychiatrist would come and interview the patients, they recognized that it wasn't depression at all, but it actually was an underlying delirium that had progressed and been unrecognized. As I said, a lot of the times the physicians don't know what the underlying cognitive baseline of the patient was. So patients may have some mild cognitive impairment at home, which precipitates and makes them more sensitive to developing delirium when they're in the hospital. The other thing is that we know that these patients that are cognitively impaired have a greater risk of developing delirium. So even very mild cognitive impairment increases the risk of delirium. The other reason that a lot of times we fail to recognize delirium is because there are different forms of delirium. Some patients that have delirium can be very hyperactive, and any nurse who's ever worked on a floor can tell you they recognize that there's something that's gone wrong when the patient starts yanking out the tubes, or they're kicking, or they're screaming, or they're yelling loudly that something bad is happening to them. But the reality is that this is just one form of delirium. It's the hypoactive patients, those patients who passively stay in their beds when we try to get them up to exercise them or to get them out of bed to sit in a chair. They're resistant. They just are very, very passive. A lot of these patients also get labeled as being pleasantly confused. And in fact, many nurses in the hospital enjoy taking care of those pleasantly confused patients because they smile a lot and they're not doing anything, and they're really much less work for the staff. And even as the physicians round and see these patients in the morning, they'll be very pleasant, and they recognize that the patient has been doing the same every day, so they assume that there's not been any change. The other thing that's important, though, to recognize in looking for delirium is that there are different entities that can look very similarly. And so this is just a very short slide to kind of describe the differences between delirium, dementia, and depression. And some of those symptoms can overlap, and there's nothing stopping a patient from having dementia, delirium, and depression. And frequently we tend to forget that. We label patients as being demented, and we fail to recognize that they may have other neurological changes that are contributing to their behavior problems. So we're going to talk a little bit now about how to assess for delirium at the bedside. And the most important thing that we can never stress enough is that it's really important to get a history from the patient or the family or someone who knows this individual very well. Because if you don't recognize that there's been a change, you're not going to recognize confusion or delirium in the patient. We use the confusion assessment method here at Stanford, and many, many hospitals around the world and across the country use this assessment method because it's very simplistic and it's easy to do. In addition, a physical exam, which includes a neurological exam and paying attention to the vital signs, is also very important. So the reason that the CAM assessment method has been chosen by our facility and chosen by many other facilities because it's so quick and easy for the nurses to learn and use. It doesn't need to be restricted to the nurses, and in fact here we've actually encouraged our occupational therapists and physical therapists to learn to use this method and recognize the fact that the patients have delirium. It's also been translated into other languages, although I don't personally speak other languages, so I don't use it in any other way except in English, but there are other countries and other languages that this is available in. And so if you have a translator that speaks the same language, you could actually teach them to use this tool in the native language of the patient. It is a very sensitive tool. And the great thing about this tool is that if you watch different people do it over and over again, you will find similar results between individual observers and users of this tool. So that's also very important from a research perspective. The CAM assessment in the short form is actually only has 4 features, and those 4 features are listed here, and we're going to go through these and I'll describe them in a little more detail. the first feature is the acute onset or fluctuating changes in mental status. This is when knowing somebody who has met this patient before, speaks the patient's language, can give you an opportunity to actually discuss how they were before they got to the hospital, or how were they the week before they got to the hospital, because some people do come in with delirium, so it's important to know what their cognitive baseline was before they got here, but also has there been a sudden or recent change in their behavior. It's also important to recognize whether or not this fluctuates during the day or in the evening. I mean, there can be a very wide variation in the fluctuation of their mental status. Some of the questions that we use, many of us, when we meet patients, use them frequently, so it doesn't require a lot of new things to learn, but asking a patient, where are you? Do you know what day it is? Do you know why you're here? What happened? Do you know who this person is sitting next to you? Can you, I mean, there are all kinds of things that if a patient can't answer those questions and normally can, one should be very attuned to the fact that this person is most likely delirious. Because if suddenly the patient doesn't know who their daughter is, or the fact that they're in the hospital because they broke their hip, there's been a definite change. The second hallmark of this particular feature of delirium is inattention. And this is a really important function because many of us sometimes just assume that the patient didn't understand us, when in reality the patient can't attend to what we're saying. They can't answer the question, they can't respond appropriately because they're not able to process. And in fact, it's sort of how people feel at the end of sitting in a class for 8 hours a day where they just can't quite figure out what the instructor's asking. It's that same kind of disconnect that some of us have felt from time to time in life. But this is a fixed problem that the patient just can't answer. And there are some very specific tests that we do for inattention, and these are some of the possibilities. I will tell you that the word world is probably the most classic means of having somebody repeat that word backwards to you. To actually spell it backwards is a very hard thing to do if you're having trouble with attention, because the letters DLR in English are not a standard word pattern, and so being able to go backwards from DLROW can be very challenging. The difficulty is that if you as a clinician do not speak English as your first language, it may be very hard for the patient to understand the difference of the word that you're speaking, because especially word and world can sound very similar. The other problem is if the patient's first language is not English, they will have a very difficult time actually understanding, or maybe they speak English well, but they don't read English or they don't write English, and so trying to spell a word backwards may be harder for them. And again, you want to speak in a language that is most familiar to the patient, so anytime when you're trying to question the patient, you want to have someone with you who can speak that language to the patient. Other things that are easier when I use translators is I have the patients count backwards from 20. So it's really easy for a translator. Some of the languages I can recognize that the patient stumbles along. Sometimes I will even use family members, but the caveat here for using a family member is you have to remind them not to actually give hints to the patient. It's really easy for the family to want their loved one to do well, and so they'll shake their head, they will nod encouragingly, but you really want the patient to just do it on their own with no hints. And then, of course, random numbers also work, like 592 is a good pattern that will take a little bit of attention. But I tend to like either the word world or counting backwards from 20. The other feature that can appear with delirium is the person who has disorganized thinking. So the person who just sort of talks about things that make no sense. They tell you stories that they begin a story and it just sort of diverges off to something else that's completely unrelated. Nothing makes sense. And in this particular instance, it's really important, if the patient's first language is not English, to have somebody speak that language of the patient, because if you're a little bit familiar with the language or the family's doing the translating for you, they may not tell you that the person is diverging away from that. They'll be talking about things and they'll just ignore that, or they won't translate it. So it's really important to have someone who's used to doing medical translation to actually help you to know what that person is really saying. And you can see there's a couple of examples here about, you know, I need the bat's RAM, or, I mean, just anything that's nonsensical and doesn't follow through can be a symptom of disorganized thinking. And then the following feature that's very important is level of consciousness. And I this is a list to be complete. We put things like coma. Obviously, we don't do this test on somebody who is comatose. There is a way to test people who are intubated in the intensive care unit, which we're not going to talk about today, but there are other ways of testing. But the important thing is to recognize if the patient is anything but normally alert. So if the person is overly vigilant, if they're picking at things, they're pulling at things, they're restless, they just seem to be moving quickly from one item to the other in their bed or in their room, that they may be overly vigilant. That's an important clue that something might be changing. And of course, people who are stuporous or lethargic, it makes sense that we would expect that there's some alteration in their mental status. So this is just a little diagram to make it easy to visually see. In order for a patient to be CAM positive, they have to have both features 1 and feature 2. Those two absolutely must be present. It's not uncommon for people to tell me that the person is alert and oriented, but they have inattention, so they must have delirium. The reality is that is not by definition delirium. You need to have both of those features to be abnormal. And then you have to have either feature 3 or feature 4. So either one of those, along with the first two, is considered to be positive. And so now I'm going to turn the mic back over to Dr. Hussain.
All right, so we are talking again about prevention. As I said, prevention is a key. So the first one is to keep the person alert and oriented to their surroundings. The second piece of prevention is getting them out early on, getting them out of bed early on in the process of hospitalization. If your patient does not have an indication to be in bed or for continuous bed rest, there is no reason to keep that individual from not going with physical or occupational therapy. So as a matter of fact, I encourage all my students to write that order early on in the process. Get the person out of bed as often as possible throughout the day, up in chair for meals, and also take them out of the room into public areas where there is sunlight, if you can afford that, and as well as removing any unnecessary attachments. So Foley catheterizations, IV fluids, if you can just disconnect these equipments and get them to move to the bathroom and feed themselves the natural way. The sooner you can do that, the better. Preventing sleep deprivation. Again, one of the risk factors for delirium is sleep disturbances. And as you see with the disorder itself, you can see an altered sleep-wake cycle. What you want to do is you want to try all non-pharmacological methods to allow your patient to sleep uninterruptedly for at least about 5 hours at nighttime. And generally speaking, what I can say about that is make sure you have orders not to do any blood draws in the middle of the night unless it's an urgent matter, no vital checks at least for about 5 hours throughout the night. Try to silence the monitors if the patient is in a monitored unit. And if they don't have a monitor, and if they are not needing a monitored unit, then move them to a unit where there is no monitor in the room. Allow the patient to listen to a favorite music or read a book that can relax them. Try to reduce the noise level at the unit. We have implemented some of that actually at Stanford Hospital, where we have abstained from using an overhead system to using phone communication. That way the nurses are not paged overhead, and that has significantly improved on the noise level in the room. As we said, schedule and bundle tests together so that the patient is not constantly being awakened to do a blood draw or to do an X-ray or an EKG. So all these and others all these methods can really help improve on the sleep cycle of the person. I just want to mention one other thing with the prevention of the sleep deprivation is if you can allow your patient to sleep at nighttime and then during the daytime try to prevent them from taking frequent naps by keeping the drapes up, by getting them out of the bed and in chair, by allowing them to spend most of their day out of their bed, that would again improve on the sleep cycle. So with the delirium evaluation and management, once you have a delirium, how do you assess your patient? So Kathleen Turner-Hubbard, nurse practitioner, have talked about the confusion assessment method, and that's a key method in identifying patients who have risk for delirium. The physical exam, again, is another essential component to studying a patient with delirium and identifying the causes of delirium. As we said, delirium is a syndrome. It's actually a sign of another disorder. It's not an entity on its own and has to be addressed as such. A lot of times people assume that it's the endpoint, but truthfully there are generally myriads of underlying risk factors that precipitated delirium, and one has to put their fingers on what precipitated delirium in the first place. So the key factors, I say, in any assessment is get a good history and a good physical exam. That will pretty much give you about 90% the diagnosis of delirium. So as we said, establish a good baseline for cognitive assessment on admission. If you do not have that, for whatever reason, use family members to aid in giving you a background about the patient's cognition. Has your loved one been demented in the past, or has a diagnosis of dementia, or been forgetful? So that will help you and help you establish a baseline on the patient. But there is nothing better than doing a good cognitive evaluation upon admission. Review medications periodically with the patient. So most people come into the hospital with a list of medications, and once they are hospitalized for an acute process, some of these medicines get discontinued abruptly, or they may be put on medications unnecessarily or necessarily, but medications that can precipitate delirium, and we'll talk about that also in the next coming slides. Get a good history about alcohol and substance abuse. You'll be surprised how many elderly people have that glass of wine every night, and it's part of their routine. And once you deprive them from that essentially they go into alcohol withdrawal. So again, get a good alcohol history is essential to working up the underlying cause for delirium. And then once you obtained your history and you did your review of the medications, look for metabolic abnormalities, for causes of infection, of heart attack, of thyroid abnormalities, or vitamin deficiencies that can potentially precipitate delirium. So I generally advocate for getting a complete blood count, complete metabolic panel, thyroid test, B12, EKGs, X-rays, and checking in oxygen saturation on these individuals is essential. In the elderly, one of the most common causes for delirium is infection. And generally speaking, most of us who have been dealing with elderly patients know that infections present in elderly in an altered fashion. So your older woman is not going to come in with classic symptoms of cystitis, with dysuria, discomfort, and fever. She's going to come in with altered mental status and either combativeness or urinary incontinence. So that's a hint that this person is likely having a urinary tract infection. So checking for signs of infection is essential, doing a urinalysis and chest X-ray, blood cultures if necessary. If they have a recent wound, looking at the surgical wound to make sure that that's not infected are all essential components of working up delirium. Neuroimaging and lumbar puncture actually play a very insignificant role in the assessment of delirium, and I would say probably less than 1% of our patients who are diagnosed with delirium actually needing neuroimaging, especially in the light of doing a good neurologic examination and finding no signs of neurologic deficits on exam. I will talk here about pharmacological awareness because, as I said, medications are one of the biggest contributors to delirium. And as you've seen in my previous slides, in orthopedic surgical patients, 40% of them can develop delirium. And I would say at least 50% of these individuals are having delirium secondary to medications. So review medications with your patients is an essential. And there are certain classes of medications that are considered high-risk medications for precipitating delirium. Anticholinergic medication by far carries the biggest risk. So delirium as an entity is a disorder of the brain where we think there is an increased level of anticholinergic activities. Cholinesterase, it's a neurotransmitter that helps increase concentration and enhance memory, and vice versa, anticholinergic activities decrease concentration and decrease memory retention. So anticholinergic medications, by virtue, they precipitate decreased memory and decreased concentration. Analgesics, again, play the same role, as well as sedatives, narcotics, hypnotics, antipsychotics, and to some degree also cardiovascular medications. This is a comprehensive list of all the classes of medications that could potentially, again, precipitate delirium. And when I show this slide, people say, well, what is left? Well, truly, I mean, there are very few medications that potentially do not cause delirium. In a sense, you have to be very careful as a prescriber when you are prescribing for older individuals, that you have a very clear indication for why you're prescribing the medication, and you have to have a very good justification for why you're putting them on that particular medicine. Again, what stands out here in this list is the anticholinergics, the analgesics, the same classes that we talked about earlier, antidepressants, benzodiazepines, and then benzodiazepines. So what do you do? I mean, obviously, we have to treat our patients. So if we have to use that particular medicine because that's what they need, we will use it. Just be aware that that class of medicine or that particular medicine can make your patient delirious. When I talk about management, again, I try to stay away from pharmacological management because, as I said earlier, delirium is a syndrome, is a sign of an underlying disorder. So try to stay away from medications just to treat delirium in itself if you can afford that. So one of the things we always say is try to avoid from restraints, sorry. Use sitters instead, because sitters will help keep an eye on the patient and prevent them from getting out of bed and hurting themselves or pulling that catheter or pulling the IV line away. Whereas restraints only contribute to their agitation and to worsening of their delirium. Try to communicate with the patient in their primary language and also use basic English. So a lot of us use medical jargon, which just only aggravates the situation and does not help. And make sure that they have their hearing aid when you're talking to them, because if you're speaking to somebody who has no hearing aid, you might as well just talk to the door or the wall next door. So make sure that your patient has your attention when you're talking to them. Adjusting the environment, as I said earlier, opening the drapes and allowing sunshine to come in, because sunshine and sunlight have proven actually to prevent delirium because it improves on the melatonin level in the brain and suppresses melatonin level, which in a sense increases alertness and awakeness. And that way improves on the sleep-wake cycle of the individual and allows them to sleep better at nighttime. Minimize the use of light at nighttime, again, because you want to allow your patients to sleep better. Again, the lack of light will increase the level of the melatonin in the brain and allows or induces sleep. Again, remove all unnecessary equipment. If your patient does not need the monitor, don't put them on a monitored bed. You're not doing them any service by that level. Behavioral management. So now we've tried everything that we can, but the patient is still really agitated and combative and just cannot be controlled, and you really have to give them the IV antibiotics to get them better. So occasionally we have to resort to the use of antipsychotics in these circumstances. Some of the antipsychotics, we have one of the older ones, haloperidol, and then the newer ones, such as quetiapine, risperidone, and zyprexa. Those all more or less actually have a similar effect and a side effect profile. There's been no significant increased risk or benefit from using one of the newer agents, except short of quetiapine probably, because there's been some advocacy for using that specifically in Parkinsonian patients and in patients who have Lewy body dementia. Short of that, you could make your choice. The negative outcome associated with these medications is, especially in the long-term use, is the precipitation of the extrapyramidal side effects. So a person will develop Parkinsonian feature with the long use of these medicines. Excess sedation, which can in itself cause the person to be bedbound and develop pressure sores and pneumonias, etc., aspiration, increased risk of fall, as well as increased risk of cardiac arrhythmias and sudden death. And actually, there is also increased risk of stroke associated with these medications. If you get called and you ask for something to help your patients sleep better at nighttime, I generally, again, recommend staying away from hypnotics and non-benzodiazepines. And there has been some literature to support the use of ramelteon, that's a melatonin-based sedative that does not have the same side effect profile as some of the benzodiazepines and non-benzodiazepines and the hypnotics. Trazodone, also good for elderly patients, well tolerated, and helps induce sleep as well. And I would save lorazepam for patients who have acute alcohol withdrawal. Those individuals definitely would need benzodiazepines to help them overcome that period of delirium. There has been few cases also of dementia patients where they respond to a low dose of lorazepam, and in that case, I would use it as well, but I would save it as a second-line agent. And then there is a huge component of management of these individuals that as a healthcare system, we have not really learned to bring into the table, but I advocate strongly for that piece, which is family and close friends. There is nothing better than having somebody who is a familiar person to that individual to be present at bedside. That individual, these family members will help not only orient your patient and keep an eye on, but also can bring into the picture their underlying condition. They can talk about areas of interest to that particular patient. They can help calm the person. And so there's a huge value in bringing the family into the picture. There is also a huge value in educating the family about about what delirium is, its presentation, its course, and what to expect. That way they can be partners with you as opposed to being of a stress source. So instruct the families to speak to the individual in a calming voice, to try to reorient the individual frequently, stimulate the patient to talk about current events. I say generally avoid using TVs in the room if possible. Books and talking is actually much better, and music is fine. Again, and educate the family about what kind of help they will need once the person is being discharged from the facility. So with that, I'm going to go back to the cases that I presented earlier and just talk briefly about how we dealt with each case and what the main issues were. So in this 82-year-old lady with the total knee replacement and the history of sleep disturbance, she ended up getting the benzodiazepines as a sleeping aid on an orthopedic floor, and that made her acutely delirious. She got out of bed, she fell and fractured, and lacerated her head. This case could have been prevented by simply having a better choice of medication, and essentially by just withholding the Benadryl or the the diphenhydramine from her medication list and allowing her to sleep more naturally, removing monitors, removing IVs. Actually, she ended up doing fine, and her delirium pretty much resolved within 24 hours. The second case of the Hispanic lady, the fact that she was only smiling and unable to follow any directions, we ended up getting a Spanish interpreter on site who helped translate and who discovered also that this person has no idea why she was in the hospital. She did not know that she was in a hospital, and she was quite confused about the date and the place where she's at. So this person was having delirium. It is the hypoactive type, as Kathleen Turner-Hubbard had talked about earlier. And so she was one of those pleasantly demented patients who just sat there, smiled, but did nothing. And recognizing that that was delirium was actually a key component, because then that individual was taken out of the room, was helped by the family members to reorient her, and eventually she did her baseline. But just knowing that she had the delirium and being able to address these issues and trying to get her out of the room and to therapy was helpful in improving on her disorder. The third case was of the 72-year-old male executive. This, again, individual did not close to the treating physicians that he was drinking 2 bottles of wine at nighttime, not 2 glasses of wine. And when he was admitted to the hospital, he acutely went into alcohol withdrawal, and in 2 days he actually developed delirium tremens. So again, was not known because he did not disclose that, and nobody asked him about it on admission. And just recognizing that that was there by having the wife provide that kind of history was actually of great help in assisting us as a team to manage his symptoms and treat him appropriately, and he was treated successfully with benzodiazepines and did improve. And my last case is of the 68-year-old Asian male. So I just want to stress the fact that in each culture there is a different perception of what disease is and what medications are, and how a person should respond or should respond to questions, or whether they ask or not ask for medications. So in the Asian cultures, it's actually a point of pride not to complain about pain. And as a man, he did not want to be seen as being weak or needing some additional help to get him through that time process. And so he was clearly in a lot of pain, did not get adequate pain control, and couldn't move and continued to decline just by the virtue of not getting adequate pain medications. We ended up actually paging the surgical service. We asked them to improve on his pain medications and make some recommendations. And it's really in about for 24, 48 hours, that person was completely different. He was able to sit up, to communicate, to have a normal conversation with his wife and a treating team, where before that he was very agitated and would not want to participate in any kind of care, and he was also delirious. So I hope that these 4 cases illustrate the various presentations of delirium in the healthcare setting, and also would draw on the importance of trying to recognize the disorder and trying to treat the underlying disease if possible, because that is really a key into improving delirium care and management. With that, I end my talk, and I'll take any questions. Thank you.
Thank you, Ms. Turner-Hubbard and Dr. Hussain. We now have some time for the presenters to answer your questions. If you have any questions, please use the chat feature located on the right side of your screen. After the Q&A, we would like to ask each of the participants to answer the short evaluation questionnaire you will find on this last slide. We will now turn to questions that participants have asked. And we will read those questions if we get them. Does anyone have a question?
So the question was posed to me here is, are there ways of identifying patients in the community with delirium? And certainly. So when I see patients in my office, especially brought in to me by their family members, generally speaking, the family is pretty savvy about recognizing that their loved one has changed from their baseline. And so they bring their loved one and they say, well, my mother all of a sudden started urinating on herself and not paying attention, not eating, not wanting to participate in any kind of activity, and I'm just worried about her. So that's just one example. Another example can be a patient comes in with, again, with being very withdrawn, not wanting to participate in any family function. And what I say basically, again, as a practitioner who care for elderly patients, is always use the family as a surrogate history provider, because they are your allies, and don't dismiss them because they know more about your patient than you know. So that's a key thing. Use the family use the history as one of the key features. The second is obviously you want to examine your patients, and using the CAM method can also be utilized in the outpatient setting. So just looking at your patients, seeing are they alert or are they somnolent or very fidgety. Ask them the questions about orientation, see if they know where they are, or is that a significant change from their baseline. And even if they have dementia, if they have an acute change in their alertness level, that's not dementia. That is generally delirium superimposed on dementia. And then try to ask further questions about their understanding of the situation, ask questions about trying to see if they are actually able to maintain their attention onto you. And so going through the CAM method certainly can be done in the outpatient setting. We have another question from the audience about going over the elements of the CAM again. And certainly I will try to go to that slide. Okay, so as Nurse Practitioner Kathleen indicated, that there are two components of CAM that are essential in making the CAM positive. They have to be there in order to, and one of the other two features. So acute onset of mental status change or a fluctuating course. What that essentially means is that you have a patient in the hospital or in the outpatient setting, and that person is acutely confused, acutely not knowing who they are or where they are, or being either overly sedated or overly somnolent. That's defined as acute change in mental status. And that can change throughout the day. So the family can tell you, or the patient, or not the patient, but somebody will tell you that they are better at times and then worse at others. The second component is inattention, which is essentially that the patient cannot maintain their attention on you. So you're asking a question and they are drifting off completely. And this is a classic when we are at the bedside and I say, I wish they can just, answer this question for me. And this is actually very frustrating to students and beginners who do not know that's the syndrome. So, but actually it is one of the cardinal features, again, of the CAM delirium is that the presence of inattention. So this is when you have them repeat the serial 20, backward, or have them say 392, 592 backward. And in either way, if they are not able to say the serial numbers or the word world backward, then essentially they are not able to maintain their attention on you. Then having those two components, look for any signs of disorganized thinking. The person will tell you, for example, that they think they're there because they're there to give a lecture, or if they are a professor. I've had professors who actually have this problem. Or that they are there because they're held prisoners against their wish. And some of them actually do not disclose that to you, especially in the hypoactive patients. They are very fearful that they will tell the next person, or they'll tell their loved one that, why am I here? Am I being held against my wish because of this or that? And so they, the disorganized thinking process can come in various ways. And then the last component is the altered level of consciousness. And this is when, again, Kathleen pointed out that anything but alert is considered altered. So if they are either overly sedated or stuporous, or they are hypervigilant, meaning they are just fidgety and cannot sit still, any of these features is considered altered level of consciousness. I hope that's clear. Sure. So the next question is, when a surgical patient are told not to have anything to drink or eat for up to 24 hours, does that contribute to delirium? 24 hours in itself, especially if they've been supported by IV hydration, should not really contribute to delirium. So hopefully the surgical team would have put them on some form of IV nourishment to prevent delirium. The IV post, however, or the IV line can contribute to delirium, just the fact that it's a form of restraint. And I guess we have one more question to say. No?
Thank you very much, Ms. Turner-Hubbard and Dr. Hussain. Unfortunately, we do have to wrap up. Our time is limited. We will respond to those questions via email. We have captured them. And again, thank you very much for the excellent presentations. Thanks, audience, for your participation. Our next webinar in the series, Applying Best Practices to Diverse Older Adults, will be April 12th from 12 to 1 Pacific Standard Time. The topic will be Behavioral Activation and Effective Intervention for Late Life Depression. If you enjoyed this presentation, please be aware that completion of the survey helps Stanford GEC to obtain funding for important educational programs. We invite you to visit the newly revised Stanford Geriatric Education Center website at sgec.stanford.edu to explore other resources in ethnogeriatrics. This is Nate Gardner, and this concludes our webinar for today. And again, I will flash the survey for your review.